Good evening, everyone, and welcome to our next installment of our AO Trauma Hand North America online series, Wrist Arthritis. This is our second offering in the series. We met a couple of weeks ago and talked about more classic treatments for arthritis. And tonight we're going to kind of go a little bit different direction and talk about some alternative treatments and whether or not they are what they are supposed to be. I'm Kim Mesra, and I'm going to be your moderator tonight. We have two wonderful faculty, Dr. Boyd and Dr. O'Shaughnessy, who are going to talk about some of the alternative treatments. We have no conflict of interest. Just to let you know that AO does not promote the use of any particular product or service or commercial entity. We are here for teaching purposes. So tonight we are going to talk about alternative treatments of arthritis from the hand and wrist, including PRP, stem cell, denervation, low-dose radiation, amongst others. Here's our learner objectives. We kind of want you guys to take away the ability to understand some of these alternative treatments and have conversations with your patients because the patients are asking about these. They are, becoming more aware of these treatments. Our schedule for tonight, I'll start, and then we'll talk about some other treatments and end with some questions at the end. We'll leave a little time in case there's any questions. I do want to let you know our online series, we're in series 1 with the arthritis, but our series 2 starts on March 19th. We're going to be talking about soft tissue coverage of the hand and wrist. We have 3 offerings in that series. And we're going to have a journal club as the last offering, talking about classic articles relating to soft tissue coverage. So that'll be great. And then series 3 is going to be the arthritic thumb. So please put those on your calendar. Also like to bring to your attention, we have some upcoming courses. We have a couple basic courses that are Sawbones courses, one in Dallas on March 28th and one in Ann Arbor, Michigan on June 6th. Those would be wonderful for residents, fellows, and anybody that just wants to review the principles. And we also have our advanced hand course in San Diego on May 14th through the 16th, which is a cadaver course. This is being recorded tonight, and there is a link that will be sent out to those registered, or you can also watch it on Ortho TV. So that being said, let's get started. I'm going to talk about orthobiologic injectables tonight as alternative treatments to steroids. We all are very familiar with steroids. We've used them for years, but there are some things on the horizon that are potentially promising. So what are orthobiologics? Well, basically, they're therapies developed from biologic or natural substances. And this can be from blood derivatives, cell concentrates, stem cells, peptides, amniotic fluid, adipose tissue. As you can see here, there's many places from which we can bring these substances and turn them into biologics. So what's the promise? Like, why orthobiologics? What's happening? Well, the promise is a big promise, and we're not sure that this is going to actually be kept or not, but the promise is reduced inflammation, fighting cell death, differentiating into multiple tissues, whether it be muscle, bone, fat, or cartilage, and then self-replicating. So it sounds wonderful, but can it really happen? So let's start with PRP, or platelet-rich plasma. This is probably one of the most commonly known orthobiologics, and it probably has the most data behind it. It's been around a bit, and it basically utilizes the patient's own blood enriched in platelets with concentration of the platelets to promote healing. It is felt to work through growth factors and cytokine modulators that improve synovitis and cartilage hemostasis and try to keep tissue as healthy as possible. It is autologous, so that's nice because there are minimal risks associated with it, and there might be some temporary soreness at the injection site, but overall, very low risk. The cost varies greatly depending on your market. Between $250 and $1,500. I'm in the Dallas market, and our probably average price here for PRP injection is about $600 to $700. So we're kind of in the middle of that range. Typically not covered by insurance, so it is cash. We do know that there are some common hand protocols that have been developed involving between 1 to 3 injections, spaced roughly 2 to 4 weeks apart for PRP. And the results may take a while, several weeks to become apparent. And this is a little bit difficult. It makes it difficult to interpret outcomes of these results because standardization is often lacking between series and between protocols. There isn't the same injection numbers. They're not spaced the same weeks apart. So we ended up comparing apples to oranges, which can be difficult to understand if the procedure or if the option is actually living up to what we hope it would live up to. So the process is to draw blood from the patient, which can be typically done in the office. And then there's a centrifuge to achieve a platelet concentration as high as possible. And then typically 1 to 2 cc's of material will be injected into the affected area. And this is kind of once the centrifuge is done, this is what you have. You have the red cells, the heavy red cells at the bottom, which we don't want. So those are discarded. We have the platelet poor plasma at the top, which we don't want, but here's the buffy coat. This is what we're after. And that's, roughly, like I said, 1 to 2 cc's in most cases. So what are some variables that affect the preparation of the PRP? Well, we've learned over time that there are leukocyte-rich PRP injections and leukocyte-poor PRP. And as data has come out, it actually favors the leukocyte-poor preparations, or often called LP-PRP, which is felt to reduce inflammatory cytokine signaling. So it actually does a little bit better. So we actually find that we don't really want the leukocytes. The other thing that has become more apparent as we've gained more data is that the platelet concentration does matter. Initially, there was kind of more of a manual, when we first started this, kind of an elementary approach to this, where you just basically centrifuge the blood like you would in the lab, and then took out that buffy coat. But now there's newer equipment. There's devices that can actually sort platelets and really super concentrate the platelets. 8 times versus 2.6 times the platelet concentration based on the device that you're actually using to prepare the blood. And we found that the higher the platelet concentration and the better the platelets, the better we're going to do. In the hand and wrist, the CMC joint tends to be the one that has been studied the most. So a lot of the data we have relates to the CMC joint. There is some wrist data as well, but not much for the fingers themselves. And in one study, it was reported about a 68% improvement over 12 months with a 2-series leukocyte-poor PRP injection as compared with steroids. So that's actually promising, and it gives us hope that this might be a good modality. There are some newer placebo-controlled studies that are using a single leukocyte-poor injection, but that hasn't really shown any superior clinical benefit over placebo at 6 months. So we think that a single injection is probably not going to be helpful. So what about stem cell? And we hear a lot about stem cells. I don't know about you guys, but I have a lot of patients ask me about stem cells. And they read it, they hear about it. It's been in the kind of in the media for good or for bad. I mean, there's been politics, etc. But in the end, I think there is some promise here. In the orthopedic arena, most of the stem cell-based injections come from one of two places. One is autologous bone marrow aspirate concentrate, and the other is adipose-derived products. So those kind of in our world, that's where we get our stem cells. Typically, the bone marrow aspirate comes from the iliac crest, and it is often centrifuged to concentrate the cells, which are then injected into the joint. The lipoaspirates are prepared with kind of a mechanical homogenation, then they're centrifuged, and then they're injected. So the preparation might be just slightly different between the bone marrow aspirate and the adipose, but the mechanism of action with both is basically immunomodulatory signaling. So basically, we're hoping that these stem cells can control cell activity, affecting cartilage biology and affecting the viability of the cells. There is some data that show some potential cushioning and maybe some visoelastic effects with the adipose injectable products. But again, that's kind of a soft data. It hasn't really been completely proven. There is also a little bit of an aside that is gaining some traction, and that is surgical stem cell, which obviously is something you're not doing, as necessarily in your office. But this is more where you combine a surgical approach with microfracture, And for instance, this would be if you had maybe you have a distal radius and you have the lunate fossa has arthritis. So you're doing a microfracture and then you're injecting the stem cell aspirate around that area and hoping that there is some, early studies are showing some symptom and functional improvement with this technique. So that's a positive. This just showing kind of the extraction. This is the one downside, perhaps, to bone marrow stem cell extraction. You can see that it's probably not that fun of a procedure to undergo. It's something that you wouldn't be necessarily doing in your office, like I said. And so it can be a little painful from the donor site. So that's something to consider as far as your setup. Now, I put this in there because I thought this was very interesting. This is one of those things that, you see, patients see this, right? And so they see this before picture. You have exposed bone, you have a meniscus that's bad, you've got cracks in your cartilage, looks horrible. A stem cell injection is done, and look what happens after. You've got this healthy cartilage, looks like a brand new knee. So none of that has been proven. And so we know that. That is not the case at all. It's definitely on our wish list, but it has not been proven in the literature. So the problem is that most of the evidence here is uncontrolled. There are many studies, but they're not necessarily well designed. Many are retrospective. There's not necessarily a nice randomized trial that just hasn't really come out yet. I think we will get there, but it's still very early. But there are some improvements in some of the quick dash scores and decrease in pain at rest in some of these CMC the arthritis studies that have been done so far. The adipose joint injection has actually maybe a little bit of a higher positivity in that the satisfaction at 6 months is about 68% and at 2 years about 50%. There is a high recurrence though of symptoms of about 60% as well. But still, it still has promise because I don't think steroids can actually compete with that as well. So that's promising. Now, one thing that stem cells are touted for is regrowing the cartilage or taking a cell and making it into a healthy cartilage cell. So the problem is, in all the literature reviewed, there is really no evidence of structural improvement with stem cell treatment yet. So maybe some symptoms and stuff, but not changes on X-ray, not changes on MRI. So that hasn't come to fruition yet. Next, talking about peptides, and these are right now very hot, and they're crazy in the kind of on this. If you're a social media person or if you're like online, especially in the fitness world and the sports world and the anti-aging arena, these peptides are really getting a lot of press, and you're hearing about them a lot. They are typically injected, sub-Q, and they're usually like a sequence of short amino acids. One of the couple of the most common ones are the BPC 157 and the TB 500, which basically just describe which amino acids are in them. So they're different from our other ones we've talked about in that they're not necessarily injected at the site. So they're not injected in your basal joint or in your wrist or your elbow. They're injected usually in the abdomen in a sub-Q location. The mechanism of action is felt to involve angiogenesis, inflammatory signaling, and tissue repair pathways. But again, we don't really have a lot of data. There's a lot of anecdotal data and certainly a lot of testimonials that are in the marketing realm trying to sell these peptides. And so there's still problems with safety. The safety profile is not well known. Regulatory standards not well known. But I think this is an interesting little marketing thing. If you read these what it says here besides, so if you use this product, obviously it's going to boost your energy, reduce your fatigue, anti-aging, weight management, improve your memory and your brain health, etc. I mean, it sounds like the magic, absolutely the magic. Everybody wants this if it does what it says. The problem is we don't know. And this is kind of one of the aspects of these peptides is that this is like a website. You can actually just order these off the internet, which is, again, different from some of our other orthobiologics that we've talked about. And these names are very, very catchy, like Live Forever. I want that one. Like Live Forever or Live Lean and Mean or the Kisspeptin hormone. So, the marketers know what they're doing, and we have to be very cautious. And I think, as you're counseling your patients, kind of counsel them that they have to be very cautious with these peptides. They're not the magic bullet. Next, we'll talk about amniotic fluid. This is obviously fluid donated from human amniotic tissue, has high concentrations of the anti-inflammatory cytokines, growth factors, and hyaluronic acid. It's believed to modulate inflammation and stimulate tissue repair. Interestingly enough, most preparations do not contain live stem cells, but rather they are using their cells to signal molecules to recruit healing cells. So it's just a little different than what some people think, that it's actually full of stem cells. Not necessarily. The problem is it's really expensive right now. I mean, it's around 2000, in many cases to $2,500 in the knee at least. There's a lot more literature regarding this particular injection in the knee than there is in the upper extremity. There's very little, yet it's just new enough that it really hasn't, we haven't gotten a lot of information from the upper extremity. But so it's expensive, but studies show that it may be superior to kind of what we've been doing, which is, our typical hyaluronic acid or hyaluronic injections in the knee. So it actually has promise. Just to briefly just showing, I mean, obviously it's harvested and there's so many things that we don't want, and they put this through filtration and they centrifuge it, and then eventually you get this little box right here. This is all we want of all these things. We don't want any of that. We just want these growth factors, enzymes, and hormones. And that's what's injected. Wanted to kind of just show you this because this is very interesting. This is the market, right? This is the orthobiologic market and the statistics of the market. It is a multi-billion-dollar industry. In North America alone in 2023 had a $3 billion market for orthobiologics. And so this is only going to get better and bigger. And if we look here, this is an interesting graph. This is down here at the bottom is 2021. So we really didn't have much. Here we are, 2025, it's becoming more prevalent. Look at the jump, 2026, here we are, and we're going to keep jumping. 2034, it's projected to be over a $15 billion worldwide industry. So it's huge and it's just exploding. So I think it's worthwhile knowing and worthwhile becoming more familiar with this, so you can kind of, again, counsel your patients and tell them what to expect. Briefly, just to wind up here, some take-home points. PRP does show promise in thumb arthritis. We know a 2 to 3 injection series is better than 1. We know that more platelets is better than fewer. We know we don't want leukocytes. We want less leukocytes. And we know that there's no structural improvement in the cartilage yet that's been proven. The cost runs from about $250 to $1,500. Stem cell, again, suggesting some improvement in thumb and wrist pain. There was one study I found that showed perhaps the MRI change of some cartilage in the wrist, meaning that the cartilage improved after stem cell injections. However, it wasn't a well-designed study and it hasn't been replicated, so we have to be cautious about interpreting that. The harvest, of course, can be painful in stem cells, as I showed the picture, and it's very expensive, right? $4,000 to $8,000 once you take all costs to get there. Peptides are very popular right now. They're hot right now, and everybody's talking about peptides, but they're unproven, so we have to be cautious. They run about $300 to $700 per month, so not super expensive, and they're easily accessible because patients can just get these, not even knowing where they're made or what they're made of or what the control is on the product, but they can just get them, and they're injecting them themselves at home. Amniotic fluid, promising, but again, very expensive. So overall, the take-home point is that these are all available, and there's, besides some local problems with harvest or pain, there's relatively few complications or side effects that have been reported. But I think you should be familiar with them and ready to counsel your patients, because the patients know about this stuff. They know it. I mean, I would say in my practice, at least once a clinic or maybe twice a clinic, somebody's asking me about peptides or stem cells, and they want to know if they can have that instead of a cortisone injection or instead of a steroid injection. It is off-label use, so it is not FDA approved. And what that means, at least in the US, is that Medicare doesn't cover it because it's considered investigational. So other insurance companies won't cover it. They all follow Medicare. So this is a cash business, which is, as you could see from my graphs earlier, definitely a big cash business. So that's all I have for tonight.
Great. Well, that was really thought-provoking. Thanks for all that information. So my name is Maureen O'Shaughnessy. I'm coming to you from Lexington, Kentucky. Excited to talk to you about some surgical options that are alternative or non-traditional. Yeah. So in 2026, I would say that most of our procedures that we think about for the wrists in particular, but also some of the small joints, we lose motion, such as a partial wrist fusion, proximal root carpectomy, or if they're maintaining motion, such as an implant arthroplasty, the question is, what is the longevity of these implants? So as you can see, these are some of our surgical options. I'm sure all of you on the call are familiar with this. But is there something else that we can do? Are there other options? And so I'm excited to talk to you about this because this is a topic that is near and dear to my heart. So first, I'm going to talk with you about arthroscopy. I'm going to talk primarily about wrist arthroscopy, but other joints could be considered as well. So for the orthopedic surgeons on the call, you might be familiar with this study, which is from our knee and sort of sports medicine colleagues that came out in the mid 2000s, showing that they actually did a study where they did patients with a partial meniscectomy, sort of a degenerative knee, versus a sham surgery. And what they found was that the patients that had partial meniscectomy with arthritis did no better than a sham surgery. So this was kind of damning for those people that we say were scoping for dollars, right? And sort of, I think, shifted a little bit of the arthroscopy knee world away from doing knee arthroscopies for arthritis. But, I reluctantly have started doing it. I came about this I had a very active 80-year-old gentleman that had wrist pain. His radiocarpal joint looked horrible, but he had this ulnar wrist pain, and he had tears on the MRIs that he kind of talked to me. I think he came with an outside MRI, and I think my resident was like, well, could we do an arthroscopy? It's like, you don't do an arthroscopy in arthritis, but I decided to try, and the guy did great. I mean, the radiocarpal joint looked horrible, but what I was able to do for him was do a TFCC debridement. I like to do thermal capsulorrhaphy for these patients. I think that really helps with the pain relief. And so that sort of got me open to this idea. And not that it's something I necessarily offer, but if there's a patient that is interested in some alternative options, I say, look, we can do, a deer UJ reconstruction. We could do a partial wrist fusion. They say, is there something else? I think that arthroscopy is something you could consider in the right patient with the appropriate counseling. You have to tell them, look, I am not going to put cartilage back in your wrist. I am not going to take away the arthritis, but the goal being to clean up some of the degenerative tissue, take out some of those loose bodies, and it may help you, it may make you worse. But if the patient is in full understanding, I've actually been very happy with my patients that have been appropriately selected and appropriately treated this way. Another great option that I think is a role for arthroscopy when we're talking about arthritis is for the evaluation of the cartilage or the ligaments. So I'm sure all of you can think of a patient where you have the radiographs, maybe you have an MRI, and you're trying to figure out, is it worth doing the scapholunate reconstruction because there's early arthritis? Or is the lunate facet good enough for me to do a PRC or a four-corner fusion, or should I do a total wrist fusion? And so doing the arthroscopy not only potentially could help their pain, but it can allow you to stage what's going on inside of the joint to help you give the best surgical options to the patient and help give the appropriate counseling for them to make the decision for themselves. Another surgery that I am a huge fan of is a radial styloidectomy. I think this is a procedure that a lot of the hand surgeons kind of forget about. We see a patient with slack wrists, they have a lot of pain, and we go straight to four-corner fusion PRC. But the goal of the radial styloidectomy, if any of you are not familiar with it, is you're making a small cut just on the styloid where you've got that early grade 1 changes, and you unload that beaking of the radial styloid. It unlocks the radiocarpal joint to help with motion and also just takes that pressure off. And so, this is kind of a surgical drawing showing you want to be perpendicular to the joint line. So it's perpendicular to the level of that styloid. So it's almost a 45-degree angle to the radiocarpal joint. And then you don't necessarily want to take more than 6 millimeters or you'll destabilize the radioscapal capitate joint. That's theoretical. I've had a lot of mentors and I personally don't think it actually destabilizes the wrist. And so I think you can probably take as much as you want within reason. And I like to do this open so I can really see and look for the instability. What I like to do with styloidectomy is combine it also with a joint lavage, take out any loose bodies. And again, you can kind of look in and get a look at the lunate facet. Moving on to my next favorite surgery is to talk about joint denervation. I think this has really emerged in the upper extremity world with the kind of advent of thumb CMC denervation surgeries, but joint denervation has been around for a long time. It comes from Hilton's law, who was a surgeon to Queen Victoria that found that any nerve supplying the muscle that goes across the joint will give off nociceptive fibers to that joint. So any sensory nerves that cross the joint, we know are going to innervate the joint. And so from that comes the idea of a denervation, where you just cut the sensory fiber, and that helps with the joint pain. You can see this list of where it has kind of progressed from the early 1900s to the later 1955s. But the one that we sort of lean toward is Wilhelm in 1955, talking about a total wrist denervation, in which he described 5 incisions to get the 10 sensory nerves that go to the wrist joint. Then I had the pleasure of training under the late and great Dick Berger, who with his very genius anatomical studies found that the AIN and the PIN give the majority of the innervation to the radiocarpal joint. And he found a single incision technique where you could get at both of these because the nerves run right next to each other through a small incision. And so he's got a nice paper sort of diagramming this from the technique he handed out for extremity journals. But this is what it looks like. So it's a small incision on the side of the wrist. You go just a finger breadth proximal to the DRUJ, about a 4 centimeter incision, come down through the skin, and then you're going to come onto the extensor retinaculum over the 4th compartment, come through the retinaculum, you're going to sweep the 4th compartment tendons away, and right on the floor of the 4th compartment, as we know from our normal wrist approach, is going to be the PIN, and that's the first drawing there. You take that out with the bipolar, get about a 2 centimeter resection. Do not violate the interosseous membrane. Then once you get your PIN out of the way, it's time for your AIN. So you come just through that interosseous membrane with the knife, and right below, if you're at this place, the AIN is right there. Through a small incision, you can get both of those nerves. So then for me, skin incision, closed up with monocryls, I put them in a short arm splint. 2 weeks later, I get them going. And so for a patient, when I'm counseling about arthritis, and I say, look, I can do a partial fusion, I can take your bones out, or we could try this denervation. A lot of them jump to it, and I've had some really great outcomes in my own practice. I had the pleasure of looking at Dr. Berger's experience at the Mayo Clinic when I was there as a resident, and in our study where we looked at just denervation without any other procedures, 70% didn't go on to have any additional surgeries. The 30% that did got about 2 years of pain relief before a conversion. And so I think this is a great surgical option that a lot of people forget about. So who's a candidate for a denervation? A young patient that doesn't want to have an arthroplasty or fusion, patients who radiographic disease don't really correlate with their symptoms, patients that want to maintain motion and grip, patients wanting a quick recovery, and then also some of the older patients that you just don't think can tolerate those bigger surgeries. This is a very quick, 2-week recovery, small procedure to do. And for me, I think I don't really nowadays generally do a denervation on its own. So I combine it with other procedures. So I'll do it with a radiostylodectomy. I'll do it with a wrist arthroscopy. You can take out bone spurs based on what the pathology you're looking for. And then for somebody like with Keenbox, you can add it to a radial core decompression. So I think this denervation is a great thing to add to a lot of patients. And the nice thing is you're not losing any options. So it's a small incision for wrist denervation. And if it doesn't work, you do the next procedure. You haven't lost a whole lot. So in the right patient, I think this is a great option. And for me, why I think maybe you can tell that I'm passionate about this, and this is one of my favorite things to do in hand and wrist surgery, is because I just really hate the fusion procedures. I mean, they work, patients are happy, but when I do them, I'm just like crying when I'm taking out those bones. And so for me, I get excited when there's other surgical options to try. Another thing is we know that there's a lot of pain catastrophization in correlation with somaticization of pain and maybe psychological pain that shows up in the hand and the wrist. And so a procedure like this, where it's not very invasive, it's a pretty quick outcome, allows you to kind of get the sense of the patient. So if there's something a little bit off, the story's just not making sense, doing something like this allows you to kind of get to know them before you marry them by doing a wrist fusion. So this is a reason I like denervation or stylodectomies. So what about other joints? Denervation is around for any other joint in the body it's been described. But like I mentioned, the thumb CMC has been, one of the more, recent sort of that surgeons are kind of picking up on. And so I've adapted this as well. I've been enjoying sort of the technique described by Dr. Kakar, which is just a single Wagner incision. There's lots of descriptions of this, but for me, the reason I do this is I like to do a trapeziectomy and tightrope arthroplasty, and I do it through a straight dorsal incision at the thumb. And so I use my same approach. I'm basically doing my exposure for a trapeziectomy, but rather than taking out the trapezium, I sort of, I'm just done at that stage. But what you do with your exposure to the trapezium is you're taking off all these nerves by mobilizing that dorsal branch of the radial artery. That's going to get all of the LABC branches, the palmar-cutaneous branches. And then I add to this bipolar cauterization of the capsule. I think that really helps sort of with the pain control and the denervation effect. and then potentially as well going in and doing a little osteophyte excision or synovectomy for the joint, depending on the radiographic findings. And here's just some descriptions of that from Dr. Kakar's paper, just showing, he has a Wagner incision, I do a straight dorsal, but just finding and isolating the various branches. There's lots of techniques described. This is not a talk on how to do things, so I won't belabor it too much, but this is sort of what I like to do for thumb CMC. I've had mixed results. I do think my outcomes with the wrist denervation are a little bit better than I have had with the thumb CMC, but I do think it's a good option to try for some patients. So what does the evidence tell us? So looking at a systematic review at the hand and wrist, these are sort of the CMC outcomes with PIP and DIP. And this paper is kind of what got me doing the CMC denervation. So they found that the VAS pain score for the thumb CMC went from a pre-op pain of 6, 7 down to less than 2, statistically significant. Now look at a comparative study for an LRTI. It's very similar, and just the recovery and the amount of exposure is so different. So that this actually preparing a talk, and I looked at the study, is what kind of convinced me to start doing the thumb CMC. And so, overall, when they were looking at wrist, thumb, they did find that they had high satisfaction rates and decreases of pain. So like I said, denervation is a quick, easy procedure, doesn't preclude any other future options to do. So this is a question that whenever I talk about denervation or argue with some of my colleagues that are not a favor, they say, well, isn't it just a placebo? And to that, I would say, yes, maybe. But if it makes your patient feel better, does it matter? I mean, I don't care if it's a placebo or not, if my patient has less pain and is happy. So for me, in my hands, I've really enjoyed these techniques. I'm happy to answer any questions or if anybody wants to reach out with options. So then for my little bonus, this is not any surgical option, but another thing that I've been pretty excited about is talking with patients about when they say, okay, doc, my options are cortisone, NSAIDs and things that, Kim has been talking to us about, like what else is there? And I talked to them about the anti-inflammatory diet. So this, there's a lot, again, of hype in the media and on TikTok about the anti-inflammatory diet. What is it? I personally don't have one in particular, but as I sort of looked through the literature and have been trying to ask my patients who have had success with it, in general, it's more plant-based, minimize red meat, minimize the processed foods and the sugars. Those are the kinds of things that really stand out in the majority of the diets that are talked about in the literature. You can see kind of here a list of the best foods to use and then ones to avoid. And, there is a lot of sort of diet science and data that says, you are what you eat. The diet really does influence inflammation and joint pain. So some specific articles that are applicable to the hand and wrist. When you actually draw the blood of somebody that has arthritis, they have elevated inflammatory biomarkers like the IL-6, the IL-4s. Those are higher in patients with pain and arthritis. And so, some of these studies found that restricting diet and exercise decreases the inflammatory levels. Then what about in rheumatoid patients? There's also a decent amount of literature in rheumatoid patients where you can study the rheumatoid factor, the levels that they have. There's more of those biologic markers that doing anti-inflammatory diet or plant-based diet actually improves the disease burden for them. It makes their RA better. Then there's kind of contradicting literature showing that maybe there's no evidence to support it, but in my hands, there's very few downsides to telling somebody to eat healthier and to exercise. And so I think this is a great thing to talk to people about, and there's enough science to back it up. And so again, like my why was I triggered to start talking to my patients about the diet? It's this patient here, and this, you can see her thumb x-ray. So she had thumb arthritis, miserable, but she did not want the surgery. This was, I think, before I was doing denervation. And so I said, here's the surgery, here's the options. And she was like, that sounds awful, but we were doing injections, and she signed up for surgery. She's like, I can't take it anymore. So then she comes in, kind of for a pre-op visit, and she's smiling, she's kind of beaming, and she's like, I don't want the surgery anymore. I was like, what happened? She said, I started doing this anti-inflammatory diet. My joint pain is gone. I was like, what? And then she told me the story about, she had done it for a while, felt a lot better. And then she went to New Orleans and with her husband, and she said, you know what? I don't care. I'm in New Orleans. I'm going to eat the food. I'm going to eat that French bread. I'm going to have the gumbo. So she went out to dinner with her husband. The next day she woke up with so much joint pain that she said, okay, that's it. Like, I'm convinced. And this patient was not one of those people that really, a little bit type A, a little bit by the books. And so for her to have had this kind of success, it's really gotten me interested in talking to my patients about it. And so I think this is a great thing to discuss. And just the last one I'll leave you with, that I, in my practice, use a lot of compounding cream. I'm not sure, if it's available throughout the world or throughout the country, but it is a topical cream or ointment or lotion that your local compounding pharmacy can make. And so they put different additives into it. It's like the concept of Voltaren, but a little bit, I say, on steroids, or because it's got lidocaine, gabapentin, diclofenac, lots of different agents. And I do think that this is a nice option for patients wanting to avoid surgery. And I'll leave it at that. And I really appreciate your time and excited for some discussion.
Thank you, Dr. O'Shaughnessy. That was wonderful. Um, while Dr. Boyd's getting her screen up, I would just like to comment, I'm thinking as you were talking, when I started, it's without revealing exactly how long ago that was, but when I started, when a patient came in with arthritis of the thumb, for instance, let's just say that, I mean, the discussion was fairly short. I mean, it was like, okay, so you can wear splint, we can do an injection, or you can have surgery. I mean, a steroid injection for sure. And now, I mean, the discussion I have with my patients now, it's actually a long discussion because they are like, if I say splint, they're like, what else? And if I say steroid injection, they're like, what else? And if I say surgery, they're like, what else? And so, and the patients know about the anti-inflammatory diet. They'll ask me, what do you think? Do you think it works? What is your experience? They'll ask about these other things, these other injectables. So they'll ask about the compounded creams. I mean, so it's it's actually it's become a very, very important and kind of a multifaceted discussion, really, don't you think?
Yeah. And I would just say that the diet, I really struggle because they say, well, which one? And I don't really have a one. So I try not to, again, bias myself or buy into something or sell somebody's book. And I just say, you know what, go online, look for yourself, because you also want them to be invested. Look around, investigate, whichever one makes sense to you, give it a try.
Yeah, no, for sure. But I think it's, like I said, I think it's important. The patients are definitely more educated. I mean, I guess, just because some of the information is at their fingertips more than it used to be, and they're more savvy with finding it, they know. So now we have Dr. Boyd, and welcome, Dr. Boyd. Thank you so much for coming to our forum and speaking to us tonight. Dr. Boyd is a radiation oncologist, and so this is a topic that I've been very interested in, and I'm just interested to see like how, like, just to get your take on it, because it is it's a kind of a different mindset, a different way of thinking about treating arthritis, but yet I think it's gaining traction, and it has definitely some promise. So take it away, Dr. Boyd.
Okay, thanks so much for having me here. I'm a little bit of a fish out of water, but so we are going to talk today about low-dose osteoarthritis and low-dose radiation for osteoarthritis. And by the end, I'm going to focus on what it is, the data that supports its use, the identification and selection of appropriate patients. I want to give you the tools to just kind of pre-counsel patients before you refer them to radiation oncology. And then just so you can answer questions of patients, ask them just to kind of review the basics about the simulation and the treatment procedure. So we're going to start. What is low-dose radiation therapy? As the name implies, LDRT is low-dose radiation therapy. And the low dose refers not just to the fact that you get a lower dose per treatment, but also it refers to the fact that you get a lower total dose. So typically what we would do for hand osteoarthritis is about half of a gray daily for a total dose of about 3 to 6 gray. The unit of radiation we use is a gray. It's like a milligram. So 1 gray is 100 centigrade. And so typically for osteoarthritis of the hands or other joints, the typical dose we would give would be a 6/10 of a gray, um, given every other day for about 5 days. And so your total is 3 gray. So kind of keep that number in your mind. And we're going to compare that in this next slide to LDRT doses versus oncologic doses. So I'm primarily an oncologist, probably 95% of what I do is cancer, but I'm starting to do more and more benign disorders. So again, think of that total dose of 3 gray. And then these are some typical prescriptions that I do for oncologic cases. So breast cancer, the patients get in a day almost as much as a low-dose arthritis patient, a low-dose RT patient would get in the entire course of treatment. So breast cancer is 2.67. They're getting 53 gray in a treatment course. Prostate cancer patients go for 5 weeks. They're going to get a total of 62.5 gray. And then lung cancer is often treated with big, huge whomping doses. So they'll get 10 gray per day in 5 treatments. So the number of treatments is the same as LDRT, but obviously the total dose is significantly greater. Um, and biologically, that's really different too, which we'll talk about in a minute about how that is different than the use that we have in oncologic cases. So one of the first things we kind of get asked about that when radiation, when it first sort of was being reintroduced in the United States is this new? And the answer to that is absolutely not new. It was initially used in 1895, actually, when some physicians noted that patients would have improvement in their joint pain after diagnostic x-rays, which kind of simulate, in some respects, LDRT. And actually, the first paper was published in 1898, was looking at 4 patients who had an improvement in their joint pain after low dose. 1933 had the first sort of modern, well-designed clinical investigation. And then during this period, kind of in the late 20th century to the mid 20th century, there was a growth in interest in its utilization. And their data, it's old data, obviously showed about 2/3 of patients had a benefit in terms of decreased pain and improved mobility. And this was done in the United States through kind of the mid 20th century until about the 1980s. It was used with some frequency, and then it sort of was all but forgotten. So by the time you get to 1998, there was a global radiation oncologist practice pattern survey. And what it showed is that less than 10% of American physicians used LDRT for osteoarthritis, but it was completely different in other parts of the world. So our Central European colleagues, more than 85% of them were regularly using low-dose radiation for osteoarthritis. And so the question is, what happened? I think one potential explanation is possibly cultural. There's a lot of obviously negative associations from World War II and the Cold War with radiation exposure. There's a lot of understandable fear and reluctance to use it because of the concern of secondary malignancies. And then from a medical standpoint, there were 2 trials in the 1970s that were touted as being negative for low-dose radiation therapy for osteoarthritis. But the interesting thing is that these trials neither explored low-dose radiation nor osteoarthritis because of the majority of the patients in the trial actually had other musculoskeletal conditions, not osteoarthritis. And the majority of the patients didn't receive low-dose radiation therapy. They used higher doses of radiation, which may be less effective. So while this died out in the United States, it continued robustly in Germany. And even now, in the German healthcare system, 50,000 patients receive low-dose radiation therapy for a variety of benign conditions. A large number of them are receiving it for osteoarthritis. And in Turkey, a full 5% of radiation treatments are actually for benign diseases. And this is so prevalent in Germany that they actually have a cooperative group. They publish national guidelines, they look at their own data, and based on that, which is one of the largest collections of data in the world we have, it shows similar to what was reported in earlier data, about 60 to 90% of patients have improvement in their symptoms. So let's talk biology. This is what radiation does in cancer. So we have ionizing radiation, creates free radicals, causes double-stranded DNA breaks, disrupts the cell cycle. Normal healthy cells can repair this damage to their DNA. Oncologic cells cannot. And so we exploit that difference, and that's why we can safely treat people, kill cancer cells, and not cause the same damage to normal healthy tissue. The lower doses of radiation are actually doing something different biologically, and this is a really busy slide. I kept it on, but we're not looking so much at double-stranded DNA breaks. We're not looking so much at disrupting the cell cycle. It's more reduced production of anti-inflammatory chemicals within the body. So you have reduced production of reactive oxygen species, decreased expression of adhesion molecules, you increase the expression of anti-inflammatory cytokines, and there's an increased apoptosis of pro-inflammatory cells. So I think the first question you hear is this new? And I think the second question you hear is, what about the risk of cancer? Because obviously that is not a fair trade to treat osteoarthritis and then increase the risk of malignancy. So estimating cancer risk is actually kind of difficult. So a lot of the data that we have in the radiation oncology literature um, is apples and oranges with what we do. So that data is based on atomic bomb survivors who received a single high dose radiation exposure to the total body. It's based on that. It's also based on long-term data, but by the nature of its long-term data, it was derived from older radiation techniques that we don't use anymore. And so it's difficult to compare them to contemporary practice. In either case, both of these data sets probably very much overestimate the risk of secondary malignancies. And so I think that's important to point out, first of all. But when you're looking at carcinogenesis related to radiation exposure, you have to look at the things that matter. So what matters? Dose matters. The higher the dose, the greater the risk of carcinogenesis. And as you saw in the earlier slides, the dose for osteoarthritis is extremely low. Age matters. Um, Part of the reason we use proton therapy for children is that it minimizes the total body dose of radiation because we know in children who are still growing, their cells are naturally rapidly dividing as part of the growth process. The effective radiation in causing cancer is much greater in children than it is in adults. So it's significant that osteoarthritis is largely a disease of aging. And so the patients that you're going to be potentially recommending for low dose radiation therapy are not children, they are largely older people. And so biologically, older people are less susceptible to that effect. Location matters. And since this is related to hand arthritis, the great thing about your hands is that they're kind of distant from the vital organs that tend to be more sensitive to developing cancer. Literally, you can position the patient's hands for radiation, as you'll see in a minute, away from the body. And so lungs are not receiving measurable doses of radiation. Liver, bones, thyroid, all of these important organs that we want to protect, we can naturally just sort of move the hands out of the way. Latency matters. So most of the oncogenesis of radiation occurs years after it's given, sometimes decades. And so if you have an octogenarian patient, you're just going to be less concerned about developing cancer because their life expectancy is so much less. And then finally, a rare one that I think would actually be important is that genetics matters. So if you see someone who is a known carrier of Li-Fraumeni syndrome or retinoblastoma, those patients are exquisitely sensitive to developing cancer from even very low, modest radiation exposures, and they would be absolutely inappropriate for low dose radiation. But I'll say, even as an oncologist, those are very rare, and you're probably unlikely to ever encounter that in clinical practice. And you're sending the patient to a radiation oncologist anyway, who would know not to deliver it in those cases. So, what does this all mean? That the risk of fatal tumor induction in patients who are receiving low dose radiation is extremely low. This was a European radiation oncology journal that tried to estimate this risk. As you see, it's related to age. And as you can see, it's really low, 0.3 in every 1,000 patients that are treated with LDRT. And the dose is similar to a single CT scan in terms of the risk of developing long term malignancy. Let's talk about the side effects, and they are minimal. So in a large review, I believe from Germany, they looked at over 1,000 patients and there was a single reported case of skin erythema. It's hard to say if that's causal or not. And focusing on the hands, there's a theoretical risk of nail changes, but part of the technique that we use for hands is we block the nail beds to minimize that risk. And I think important because, as we just heard about all these wonderful procedures that are available, doing low dose radiation would not preclude the future appropriateness for that patient to receive surgery or any other form of interventional procedure. Let's look briefly at clinical data. I want to focus on some high points. There's a large retrospective study in Germany. I think the key take home points from this is that approximately 2/3 of patients had a reduction in their pain that was seen at variable time courses. Some saw it immediately, some saw it 8 weeks after. I think another important point of this study is that a large number of patients required a second course of low dose radiation to get optimal pain relief. But even in those who did not have an optimal response to the first course of radiation, a second course given a few weeks to months later resulted in a 61% improvement in their pain. This is a good study that was specific to hands, and that's why I included it. This was basically 100 patients that used a pain scale to measure the patient's subjective pain scale to measure the patient's response to radiation, 94% improvement in pain. That also includes people who had a second course of radiation. This is a prospective trial that I think is important because it really looked at how it had some of the longest follow-up that's been published with 38 months median follow-up. And 62% of patients who had initially had improvement in their pain maintained improvement in their pain at 38 months. There is some randomized data, just to briefly focus on those. The ArthroRad trial was looking at finding the most appropriate dose. This trial is actually looking to answer the question between low dose radiation therapy and very low dose radiation therapy. So they perceived the standard 3 gray that we're doing here, and then they compared it in a randomized fashion to a tenth of that dose. Unfortunately, that trial closed early, however, but preliminary data suggested that even a lower dose may work just as well. There have been randomized comparisons between low dose radiation and sham radiation, which is placebo radiation. The therapists just go out and surf the internet, and the patient thinks they're getting radiation. That has shown an improvement of low dose radiation versus sham. There's also a randomized trial that showed improved pain control with low dose radiation versus glucosamine and chondroitin sulfate in knee arthritis patients. Of course, there have been a couple of trials that did not show a benefit to low dose radiation. The Menton trial and the Mahler trial had both very similar designs, small numbers. They looked at 6 gray of radiation versus sham radiation. There's a couple of criticisms. They're very small trials, only 50 patients in each. Critically, no retreatment was allowed per their trial designs. And as you saw in the larger retrospective studies, that's an important component of implementing that for some patients. And they used a higher dose that may not have been effective. So let's look at the appropriate patients to send. Osteoarthritis is not appropriately treated first line with low dose radiation. You want to have patients who have tried other more traditional therapies. They need to have had pain or inflammation that's chronic, 3 to 6 months. Due to conservative estimates of oncogenic risk, you still want a patient that's older than 40. And then the obvious contraindications would be pregnancy, septic joint, or known genetic susceptibility to ionizing radiation. If you're talking to your patients about the pros and cons, the pros would be there's about a 60 to 70% improvement in their pain, minimal side effects, risk of secondary malignancies is very low. An important one that patients ask about that's very important to them is that they are not radioactive. And a lot of people have a lot of anxiety about that. You can reassure them they are not. And also, I think importantly for our American audience, most private insurers and CMS do cover LDRT for osteoarthritis. The cons are that it is not a quick fix. Many people can take up to 4 to 12 weeks for improvement, so it's not an instantaneous benefit. There's a small time commitment. People have to come for a measuring session and then typically 5 treatment sessions, which each last 15 to 20 minutes. They need to be able to tolerate the treatment position, and I'll show you that in a minute. And also they need to be counseled that sometimes a second course is necessary for optimal outcome. Let me just talk you through the simulation process. And this is what I talked about. They need to be able to tolerate the treatment position. I'm finding this in some patients. We position them prone with their hands out of the way, and some people are not able to do this. So really debilitated patients, just the fact that they have to be able to get into this position alone can sometimes make it not a good option. Once you're in this position, we do a CT scan for planning. There's several treatment devices that we use. On the left, you'll see an aquaplast immobilizer that's just custom fitted to their hand to prevent movement. On the right, you'll see bolus, which helps bring the dose superficially to cover the joints. And I'll show you some visual examples of that. This is commonly what a radiation treatment field looks like. You can see that the nails are blocked. This is actually one of my patients. One thing you may notice is that we're treating the whole hand. That's kind of the most common practice rather than trying to isolate the individual joints since it's a chronic disease and the dose is so low, we just usually treat the whole hand. These are axial and coronal views of the CT plan for radiation. You'll notice that the red is hot, the green on the top is cold. And the reason we put the bolus on is that it creates the buildup of the doses in the bolus, which is on top, so that the joints receive full dose of radiation. And as a side note, it can also be used for other joints. This shows the hip and the knee. And take-home messages, years of data for low-dose radiation with a good safety profile, typically a 2-week time commitment, 70% efficacy, and it would not preclude other treatments that might help them down the road. And these are my kids, and I would love to answer any questions if you had them.
Thank you, Dr. Boyd. That was wonderful. I learned a lot from that. We do actually have a question from one of our participants, and the question was, would this procedure or this treatment be contraindicated in patients that already have a prior history of cancer?
No, in fact, those are some of our best patients because they've been through high dose radiation and they are not the least bit intimidated by low dose radiation. Another useful application I found, a lot of the medications for breast cancer can exacerbate osteoarthritis, and low dose radiation can actually help our patients successfully remain on their aromatase inhibitors for their breast cancer.
Oh, that's very good. Another question that I have for you is, as I'm seeing my patients, I mean, we have our typical osteoarthritis patient, which is typically maybe late 60s, early 70s in
Hmm.
age, or somewhere in that range. But there is this subgroup in their mid 40s, typically female, but not always, but in their mid 40s, perhaps a strong family history, having joint pain, but not a lot of changes yet on x-ray, but definitely symptomatic. Some of them will have some change, but they're just very young, right? They're very
Hmm.
young to start talking. Would Could this treatment be used almost prophylactically for that age group, or is that just really not an indication?
I would tend to say no, primarily because if for no other reason than a lot of the documentation that I have to do to get it covered by payers, I have to outline the fact that they have, failed other modalities. So I don't know that it would be like something that I would use that early in their management. I think unfortunately I would reserve it a little bit.
Yeah.
The age is not an issue. I think it's more the issue of they need to demonstrate that we have tried other things first.
So for this particular diagnosis, the low dose radiation would be more after an established diagnosis has been done. So it's actually more for
Correct.
it's for
It's
treatment. It's for,
it's
yeah, people that
treatment.
actually have the
Yes,
arthritis versus, I mean,
correct.
not that our topic is Dupuytren's
Hmm.
contracture tonight. That's another different talk. But
Yeah,
in Dupuytren's, we kind of flip the coin a bit, right? We're trying to catch it
right.
before it gets established. So it's the low dose
Hmm.
radiation. So it's a little different that in that respect, wouldn't you say?
I think you're right. It's more treatment, less preventative.
Yeah.
Doesn't stop progression, stops symptoms once they've already occurred.
How would you tell our participants to counsel their patients and to kind of set the stage for a referral to someone with, just to a low dose radiation treatment? I mean, how should we broach the subject? I mean, because you don't want to scare the patients, and sometimes they hear radiation, and there is a little bit of a stigma, right?
Sure. Yeah,
So,
sure.
what's the best way of counseling our patients to prepare them for a consult?
So I think one of the best ways is to kind of say, it is radiation, but it's a completely different procedure than what cancer patients are receiving. It's a different dose. It works in a different way. The side effect profiles are really different. It's painless and non-invasive. None of the negative things that people are frightened about with radiation will happen to them. There's no nausea, there's no hair loss, there's no immunosuppression. They don't have to isolate. Um, to be fair, I mean, most of my consultations, I mean, I think just encouraging them enough to go meet with a radiation oncologist is a huge step because a lot of my time is spent in that kind of reassurance and education. So I think it's just reassuring them to keep an open mind and just meet with someone.
Right. So this is a question for both you, Dr. O'Shaughnessy and Dr. Boyce. So one of our participants is asking, so how do you decide if a patient comes in and they have grade 1, grade 2, they're early, how do you decide between, low dose radiation versus radial styloidectomy or some injectables or other treatments? How can one kind of guide the patient to which treatment option is the best for them? And Maureen, if you want to make a comment first, and
Yeah, I mean, I think that's a great question. I think it's really up to the patient. And honestly, we could probably each spend 2 hours with every single one of our arthritis patients talking about all that we know about arthritis. So I think it's really up to the patient what their interests are and what they're looking for. I personally haven't referred for radiation, but now I'm going to make friends with my local radiation oncologist because this sounds very exciting. So, but I do like, Kim, there was a second part to that question, which I was actually going to ask Jessamy too.
Yeah.
The second part was, what about like a traumatic or osteoarthritis versus inflammatory, like rheumatoid arthritis? Is there any good for the
Yes.
illustration for more of the inflammatory arthropathy?
There's one study that showed it didn't help. It's basically the answer. Now, sometimes I've had a patient or two, it doesn't harm, but if a patient was referred to me with rheumatoid arthritis, I would probably respectfully say, and I just don't think I'm the right thing for you. I've had a couple of patients that I've had where I was like, I'm not sure if it's a little bit of column A, a little bit of column B. And I feel like in that case, I can treat them knowing that if I'm wrong and it's rheumatoid, it's not going to hurt, but it's not going to help. But to the extent that it may be mixed, it may be helpful. And it's pretty low risk. So if I'm wrong, I haven't caused harm, you know.
Dr. Boyd, we have a couple more questions. Is it typically covered by insurance in most cases?
In the well, I can only answer for the United States. CMS does, that would be Medicare, Medicaid. And I have not had denials from private insurers. I think some of that is patient selection and documentation. But I have had good luck with that being covered. I did have one patient that it was not. And we, for all of my OA patients, I always have them meet with our billing person because I'm like, hey, this is not cancer. We do not have to do this. Find out what the financial toxicity would be before we even submit anything other than a consult charge.
Yeah. And what about any thoughts treating arthritis in the elbow or shoulder with this
Yep.
treatment?
I did a gentleman to the knee today. It works for shoulders, knees, spine, hips, feet, same dose. The size of the joint doesn't really matter.
I see. Dr. O'Shaughnessy, one more question for you back to our diet. Do you have any recommendations for specific foods that you would perhaps tell a patient to concentrate on or to try to promote the benefits of the anti-inflammatory diet in particular?
Mhm. Yeah, so I generally always talk to patients about some of the ones that we know that are kind of antioxidant, anti-inflammatory, which are turmeric, ginger, caspase, and some of those things that you can add to your diet. Then the things I think that we kind of know about, salmon, sort of omega fatty acids and things like that can be helpful for joint pain. I do think glucosamine and chondroitin still have a role, and I do recommend those as well. And then, I think the things to avoid maybe a little bit more where I've seen the most of my patients with success mention, and it's the wheat, sugar, and I think processed foods. Those seem to be the ones that kind of come up the most as being the most bothersome.
Yeah. I mean, I find patients, we used to talk salt was bad, it's actually sugar. Sugar's bad. Sugar is the culprit. So and I also have my patients, I also recommend tart cherry juice. I don't know if you have recommended that as that's in your, I mean, but that's another one that's a kind of a natural anti-inflammatory. Um, so another question that we've just received is there has diet changes, to your best knowledge, ever shown any change in the blood work in regards to inflammatory markers decreasing? Does that kind of translate?
Yes. And that was from the esteemed Dr. Zabo who joined us in the call. Yes,
Yes,
there actually is literature that the IL-6 markers decrease in patients that are on a restrictive diet that are obese with osteoarthritis. And then in the rheumatoid world, the rheumatoid markers have been shown to be decreased. There are some studies where it's mixed, so it's kind of, that not the most overwhelming diet overall, but there's a decent amount of studies that show that the actual inflammatory markers improve with sort of anti-inflammatory diet or just dietary changes.
that's great. Let's see what we have here. Um, just looking through our
If you don't mind, there was one asking about therapy if you know how
Yes,
to
about
express that.
therapy. That's right.
So, you know,
Therapy.
we do know for, again, the orthopedic people on the call, for like hip and knee arthritis, PT and strengthening of the muscles around the joint, we know do really help with decreasing pain, especially for back pain. And so for the hand, the wrist, there's not quite as much, but I do think in sort of thumb arthritis, strengthening of the first dorsal interosseous has been shown to be pretty helpful. So I do think there's a role. The other thing I really commonly recommend hand therapy for arthritis just because our therapists are such valuable colleagues. They spend an hour or 2 hours with our patients talking about these things that we maybe get 5 or 10 minutes in sort of the way that our, you know, our world is right now in clinic. And so just some of the kind of basic things that you might not think to even mention when they're sitting there with a patient that might have a lower health literacy or just you know, a lower understanding of things. I think it's extremely beneficial, even if they're not giving them stronger muscles. I think just some of that talk therapy is so helpful.
Yeah, no, for sure. Last question I think we'll kind of entertain tonight is do you have a panel, an inflammatory panel, or anything that you do like to routinely get as blood work for baseline inflammatory markers?
Mm. I don't. I do send patients pretty frequently to screen for inflammatory arthropathies. So I have a panel that I worked on with my rheumatologist, not for osteoarthritis, but like you mentioned, Kim, a patient in their 40s that's having a lot of joint pains. I
Yeah,
am very quick to pull the trigger. So it's a rheumatoid factor, CCP, ESR, CRP, um, and then the thyroid levels as well. Those
yeah,
are
the
kind of a
thyroids.
good screening, and the rheumatologist, even if it's a negative hit, like if you can, I've caught so many people with something and you can change their lives. You can
Yeah,
reverse the joint damage with
yeah.
medication.
I mean, I guess I have my inflammatory panel kind of, it's similar to, what you were just saying is that I have it kind of it's a kind of a like a general screening, including ANA and anti-DNA and IL-6, and there's some other things that you're screening for lots of stuff at the same time because usually these patients are a little bit of a puzzle, right? So um, anyway, but I think that's great. I do appreciate so much, Dr. Boyd, Dr. O'Shaughnessy. I appreciate your time. You guys did great. I hope the audience enjoyed our discussion tonight. Just to give like I said, it's not like we talked a lot of surgery tonight, but we talked these are important things for our patients, and I think it's important for us to be familiar with all these things so we can counsel them and give them a better chance at symptomatic relief. So with that being said, I think we'll say good night. And again, um, we have our next installment will be coming up with the soft tissue series. So please look forward to that and please register and join us. And we'll hope to see you guys soon. Have a great evening.